The facilitator for today's session is Madeline DePina, who is an immunization nurse with DPH. Madeline?
Thanks, Ted. As Ted mentioned, my name is Madeline DePina, Regional Immunization Nurse for the Southeast and Metro Boston area. It is my pleasure today to introduce our speaker, Lori Courtney. Lori is the Immunization Nurse Manager and Perinatal Hepatitis B Coordinator in the Immunization Division at MDPH. In this role, she is responsible for nursing activities related to communicable disease control, infectious disease response, and vaccine preventable disease. She is the Massachusetts coordinator for the Perinatal Hepatitis B Prevention Program. Lori serves as a resource for providers and the public surrounding immunization information. Lori has a wide range of healthcare experience in a variety of complex settings, including acute care, intensive care, home care, public health, transitional care, and private industry. Welcome, Courtney. Lori Courtney, I'm so sorry.
Thanks, Madeline. It's really great to be with you all today and to be the one to jumpstart the spring immunization updates. I have no relevant financial relationships to disclose, and as is typical in any presentation about vaccines, I may discuss the use of vaccines in a manner not approved by the FDA, but in accordance with ACIP recommendations. And we're here today to take a look at the immunization schedules, in particular to point out some of the things that are new or changed this year. We'll take a look at the child schedule, the adult schedule, the school immunization requirements, the vaccine adverse event reporting system, and we'll leave you with some of our favorite resources. I haven't yet figured out how to make this presentation edge of your seat exciting, but I can tell you what's exciting to me, and that's every day going to work to try to reduce illness and suffering related to vaccine preventable diseases. Vaccines are absolutely amazing. How amazing is it that we can actually train our immune systems to fight off diseases without actually having to suffer through the disease itself? I recently heard the statement, vaccination occurs at the speed of trust. So I wanted to say kudos to every one of you for everything you do every day, on good days and bad days, through pandemics, through misinformation, having to deal with Dr. Google. Thank you for doing everything you can to gain and keep your patients' trust and to educate yourselves and your patients and anyone else who will listen about vaccines. And I want to do a special thank you to Drs. Wody and Murthy from CDC, who so kindly allowed me to use some of their screenshots in my slide presentation. Okay. As I said, over the next 45 minutes or so, we're going to be discussing the immunization schedules. And some of you may be wondering how the recommendations come to be, or how to explain it to patients or even to family and friends. And this is a really good short 5-minute video from the Public Health Foundation and CDC that explains the process, the science, and the safety behind vaccine recommendations. All right. So there are 2 separate schedules. There's the child and adolescent schedule, which covers people birth through age 18. The adult schedule, which is for those 19 and older. And these schedules are updated each year. They represent current approved ACIP policy. They're published every February. Once the new schedule is published in the MMWR and released, you should no longer be using the old schedule. And the schedules are approved by the CDC director and the professional societies that are noted on the schedule. Any changes that occur during the year will be published in another MMWR. And who exactly are the approving partners? The immunization recommendations are made by ACIP and approved by CDC and these listed professional organizations. Both schedules, both the child and the adult schedule, are approved by the organizations listed in the center of the screen, the American Academy of Family Physicians, American Academy of Physician Associates, American College of OBGYNs, and the American College of Nurse Midwives. In addition, the child schedule is approved by the American Academy of Pediatrics and the National Association of Pediatric Nurse Practitioners. And in addition to the organizations in the center, the adult schedule is also approved by the American College of Physicians, the Society for Healthcare Epidemiology of America, and new this year, approved by the American Pharmacists Association. In my experience, most people use and rely on the printed or laminated immunization schedules, but I want you all to be aware of the wealth of information that's available on the ImSchedules website. Here are screenshots of the child and adult e-schedules, and you can just Google CDC immunization schedule and you'll easily get here. I want to point out the greenish blue boxes. These remind you that whenever you are using the schedules to determine which vaccine someone needs, you should always refer to all the tables, the notes, and the appendix. Also, from the e-schedule, you can easily find links that allow you to print copies of the schedule, to download the schedules app, to sign up to get notification emails when updates are made. And that's true of most CDC websites. You could put in your email address, and whenever the page is updated, you'll get an alert. And you can also find a tab that says Schedule Changes. And that will allow you to easily view all in one place what changes have been made this year, or whatever year you're looking, in the schedule. A couple of other really nice features of the e-schedule are that when you click on the vaccine hyperlink, for instance, the blue where it says varicella, it will take you directly to the notes for the vaccine. And when you click on the gray information button, the little gray circle with the eye in it, it will take you directly to the CDC vaccination information for healthcare professionals for that vaccine. And every year, details covering all the changes made to the schedule can be found in the MMWR and also in that Schedule Changes tab located on the eSchedules website. So I'm going to go through some of the changes on this year's schedule. And I apologize because the pollen is getting to me a little bit, so I have a little cough. First, we'll take a look at the childhood schedule. All right. This should look familiar to you all. It's the front page of the print schedule. And on the left in gray is the list of vaccines, abbreviations, and trade names. This year, there have been 3 edits to the table. They've added COVID-19 vaccines, Priorix, and PCV15 to the table. PCV15 can be used interchangeably with PCV13. And Priorix is a GlaxoSmithKline MMR vaccine that was licensed in the US last summer. It can be used interchangeably with Merck's MMR2, which we've been using for decades in the US. I do want to point out, though, that although they can be used interchangeably, it's important to know that there are administration and storage and handling differences between the two. Just in February of this year, the FDA actually approved IM administration of Merck's MMRV family of vaccines. So that's Merck's MMR2, varicella, and MMRV. Those vaccines can now be administered SC or IM, but the new Priorix is not included in that approval because it's new and it hasn't been included. It wasn't included in the study data. So the new Priorix is only authorized for sub-Q administration. Table 1 shows the recommended child and adolescent immunization schedule. The vaccines are listed on the left and the ages along the top. This year's changes include in the PCV row, PCV 15 was added. In the polio row, there's now some print overlay all the way to the right for the 18-year-olds, advising you to see the notes for some specific guidance. And a COVID row was added. It's yellow from ages 6 months and up, indicating that COVID is recommended for everyone 6 months and up. And it has some overlay text directing you to go to the notes for more information. I want to point out, and I'll point it out several times during this webinar, that the recommendations change frequently. They've changed since this schedule was published. It's important to always go to the clinical considerations for COVID-19 vaccination for your most recent up-to-date primary source of information on COVID-19 vaccines. Table 2 is the recommended catch-up immunization schedule. It's for children and adolescents who start late or are more than a month behind in their vaccines. This year, there was only one edit to the table. They clarified the PCV dose number 4 minimal interval note. Table 3 is the recommended schedule by medical conditions or other indications. Again, the vaccines are listed on the left, but here along the top, instead of ages, you see other things that should be taken into consideration in addition to age, such as immunocompromise or diabetes. Here in Table 3, a COVID-19 row has been added, and there's some text overlay telling you to see notes for specific information for kids with certain underlying medical conditions. And remember, for everyone, the recommended COVID schedules are different for people with moderate to severe immunocompromise. And the notes section contains really important details, and it's meant to be used in conjunction with the rest of the schedule. You know, you don't always have to go searching far for information. Many of your questions can be answered by looking in the notes. And I'm always amazed at the amount of detail they're able to get into the schedule, including the notes. This year, most of the changes in the notes section were made to improve readability. And this year, the vaccine injury compensation information was revised to include information for COVID-19 vaccines. Within the notes, you will find information on COVID this year, but again, the information is already outdated, so please be sure to go to the clinical considerations. And when you look at the dengue notes, I think this is a really nice example of the amount of detail that can be found in the notes section. In Table 1, we saw a yellow bar for ages 9 through 16 and a few words of overlay. But when you go to the notes section, you see really important details, that it's a vaccine for those 9 to 16 years old who live in endemic areas and who also have laboratory confirmation of a previous dengue infection. And it goes on to detail how the vaccine is given and what areas of the globe are considered to be endemic. It's a lot of information in a little tiny area. This year, the dengue note was also clarified to more clearly state that this vaccine should not be administered to children traveling to or visiting endemic dengue areas. It's only for kids who actually live in those areas. And most of us in Massachusetts will never actually administer dengue vaccine, but I have listed some nice resources in a box on the slide. The hepatitis B note has been revised to highlight recommendations for infants both who are born to Hep B surface antigen positive mothers or whose antigen status is unknown. And also Heplissav B and PreHevbrio were both added to the catch-up vaccine section as options for those who are 18 years old. The meningococcal ACWY notes was updated. They want to bring awareness that there are now 2 Menveo formulations on the market, and one should not be used for those under 10 years old. The formulation that should not be used for those under 10 is the newer 1 vial, all liquid, no reconstitution needed formulation. And when I last checked a couple weeks ago, this formulation was not yet available to order from CDC or MDPH. The Menveo vaccine that we're more familiar with is the 2 vial formulation, which has been approved since 2010 in the US and can be used for ages 2 months and up. Menactra is no longer available for order by CDC or from MDPH, and that's because Sanofi is phasing out Menactra in favor of their Men-Quad-5 vaccine. And I've listed the current Men-ACWY vaccines and the ages they can be used on a box, in the box on the slide. I also just want to let you know that ACIP has been discussing 2 pentavalent formulations. So that would be Men A, B, C, W, and Y. That may be an option in the future, possibly as early as later this year. We'll wait and, and I'm traveling through, sorry about that. So we'll wait to see what ACIP has to say about that, but I at least wanted you to be aware of it. The pneumococcal note was revised to include recommendations for the use of PCV15. There are now 2 pneumococcal conjugate vaccines licensed for pediatric use, and they can be used interchangeably. There's PCV13, PCV15, they can be used interchangeably. We also expect approval of PCV20 for use in the pediatric population sometime in 2023. And we get a lot of questions about pneumococcal vaccines, and I have included some of our favorite resources in the resource slides at the end. In the polio notes, a special situation section was added to include recommendations for those who are 18 years of age and who are at increased risk of exposure to poliovirus. And I'll discuss this more in depth when we get to the adult section. Also, just another thing I wanted to make you aware of, ACIP has been looking at and discussing the use of a novel oral formulation for use in outbreak situations. And in the United States, as you know, we moved from using the oral vaccine to using the inactivated injectable vaccine. We did this for a variety of reasons, but the oral formulations, which are live attenuated, not only protect, but also inhibit transmission, which would be very beneficial in outbreak situations. So another thing we're waiting to hear updates from when ACIP meets. The appendix is a guide to contraindications and precautions. At the top is a link where you can find the COVID-19 contraindications and precautions. Also, the contraindications header was clarified and is now labeled contraindications or contraindicated or not recommended. And the first page is devoted to flu vaccines, and the other vaccines are listed on the other pages. Throughout the appendix, some bullets have been added. In the dengue row, they added language stating that lack of laboratory confirmation of previous dengue infection is a contraindication. In the hepatitis B row, Heplisab B and PreHevrio, language has been added that they are not recommended in pregnancy due to a lack of safety data in pregnant women. You're advised to use another Hep B vaccine if vaccination is indicated. And they've also added a link to pregnancy registries in the footnotes in case either Heplisab B or PreHevrio are inadvertently administered. And in the HPV row, there's language that says HPV vaccination is not recommended during pregnancy. Here I've summarized some of the changes made this year. And remember, a list of all the changes can be found either in the MMWR or on that tab on the e-schedule. Let's take a look at the adult schedule. Again, this should look familiar. The blue scene, the front page of the adult schedule. In the gray box, you see a list of the vaccines, their abbreviations and their trade names. This year, COVID-19, Prehevbrio, and Priorix have been added to the list. Also, the PCV has all been combined into one row with both PCV 15 and PCV 20 listed. And a reminder, there are now those 2 MMR vaccines licensed in the US, the older MMR2 and the new Priorix. They can be used interchangeably, but remember the older MMR2 can now be administered SC or IM, and the new one, Priorix, is only authorized for SC administration. Table 1 is the recommended adult schedule. A COVID row has been added, and the entire row is yellow, indicating that it is recommended for all adults across the age span. In the MMR row, there's some overlay text that has been added for healthcare personnel 65 years of age and older. It's referring you to notes with some important information that's specific to healthcare personnel in this age group. For the general population, being born before 1957 is considered sufficient evidence of immunity. However, for healthcare personnel in this age group, if they have no other evidence of immunity, the recommendations do advise you to strongly consider vaccination. And the Hep A row, there is now overlay text saying that the vaccine series could be a 2, 3, or 4 dose series, depending on the vaccine. And this is to account for a 4-dose accelerated twin-risk schedule, which is really mainly used for travel to endemic areas. Table 2 is the recommended schedule by medical conditions or other indications. Here again, instead of ages along the top, you see other things that should be taken into consideration, such as pregnancy, chronic liver disease. And there was only one major change this year on this table, the addition of a COVID row. Like in the child schedule, the notes section has lots of great and detailed information, and most changes this year were made to improve readability. And again, I remind you to go to the clinical considerations as your primary source for COVID-19 vaccine information. Hep B has been exciting in the last year or so, and the Hep B notes point out that hepatitis B vaccination is now routinely recommended for all adults 19 through 59 years of age. This universal guidance came out in 2022 when we moved from a risk-based vaccination strategy to a universal strategy. Hep B infection causes significant illness, and it's the leading cause of liver cancer. And nearly 70% of adults in the US are unvaccinated, and for Hep B, and about 2/3 of those living with the virus are unaware of their infection. So having a universal vaccination recommendation is a really important step in the elimination of hepatitis B. The notes also clarify when to use a 2-dose, 3-dose, or 4-dose series. And there's a note reminding you that Heplisav B and Prehevbrio are not recommended in pregnancy. The Hep B notes also provide a good amount of detail regarding routine vaccination for those 60 and older. And it says that for those people that do have risk factors, they should be vaccinated, and those without risk factors may be vaccinated, and the risk factors are listed. So again, universal recommendation, anybody from birth all the way through the age spectrum can be vaccinated with Hep B. And to summarize the adult Hep B recommendations, the following groups should receive Hep B vaccination: all adults 19 through 59, and all adults 60 and older with any risk factors. And then there's that permissive may vaccinate any adults 60 or older. And because it's now a universal recommendation, you don't need to get into the weeds with people about it. You could just go ahead and offer it and let people know the benefits of Hep B vaccination. And I've listed some of our favorite Hep B vaccine resources in the box on the slide. And in March of this year, the CDC actually published updated recommendations for universal hepatitis B screening of adults. Previous screening recommendations were for at-risk populations only. And the recommendation now is that all adults age 18 and older be screened at least once in their lifetime using a triple panel test. And this new universal screening recommendation nicely complements the universal vaccination recommendation. This MMWR has a lot of really great information, graphs, tables, explanations. So if you deal with this population at all, it's really worth taking a look at. The influenza notes have been detailed even more than in past years. It includes information for those 65 and older. Reminder that there is now a preferential recommendation for either high dose, adjuvanted, or the recombinant flu vaccine for people 65 and older. CDC provides no preference between those three. And also they go on to state that if one of those three is not available, then any other age-appropriate flu vaccine should be given. You don't want to miss an opportunity to vaccinate when somebody's in front of you. The pneumococcal note actually was fairly substantially updated to reflect the new recommendations for the use of PCV15 and PCV20 in people who have been previously vaccinated with pneumococcal vaccine. They also added a hyperlink to the CDC's Pneumo app, which I'll have another slide on that later in the resources. The notes start with routine recommendations for adults 65 and older, and there's a breakdown of what to give based on past immunizations. And then there are recommendations for special situations for adults 19 through 64 with certain conditions and certain risk factors. The overall general guidance is to give either one dose of PCV20 or one dose of PCV15, and then a year later, PPSV. Again, very complex, as is so many things with the vaccine schedule, but there are some really good resources. But again, somehow in my mind, I have found it useful to just think a dose of PCV20, the higher number, or a dose of PCV15 and then a dose of PPSV a year later. And that minimal interval of a year can actually be lessened for certain groups if they have certain immunocompromising conditions or cochlear implants. And again, details are listed in the notes section. And I do have several recommended resources in the resource section of the slides. The polio note has been updated to address recommendations for adults who are at increased risk of exposure to polio virus. And, last year there was the polio case in New York State, and there's a lot of questions being asked about vaccinating for polio. The notes in the immunization schedule point out that routine polio vaccination of adults who live in the US is not necessary. We may be getting some updated guidance and language in June after the ACIP meeting, but in general, unless specifically suspected of not having been vaccinated, most adults born and raised in the US have been vaccinated for polio. If you have an adult patient who is known or suspected to not be vaccinated, then go ahead and complete a series. Also, adults who are at increased risk may get one booster, but current data do not indicate the need for more than one single lifetime booster of IPV for adults. The zoster note was updated to provide some clearer guidance that you do not have to have serologic evidence of having had varicella before giving zoster vaccine. But if you do happen to become aware that a person is susceptible to varicella, then you should follow guidelines for varicella vaccination first. The notes also add more detail for people with immunocompromising conditions. And remember, zoster vaccine can now be given down to 19 years old if a person has immunocompromising conditions. The appendix is that guide to contraindications and precautions. The first page is the flu vaccines. The other pages are for the other vaccines. And within the appendix, the hepatitis B row has been revised to state that Heplisav B and Prehevbrio are not recommended during pregnancy. And they've added that hyperlink to the pregnancy registries if there's inadvertent administration of those two vaccines. And in the HPV row, they've added language stating that HPV vaccine is not recommended during pregnancy. And here I've highlighted just some of the changes this year. And again, remember, all the changes can be found in the MMWR and on that link on the e-schedule. And now I want to talk a little bit about COVID-19 vaccination. Again, it has been complicated. We all recognize that. And in April of this year, we had the most recent changes and updates to COVID-19 vaccination guidance. We expect more this fall. Please be sure to bookmark the clinical considerations and use it as your primary source. I can tell you that as of this morning, the standing orders have not been updated. I check multiple times a day. We get that question multiple times every day. The updates this spring and those expected this fall are actually meant to help usher us into the new phase of living with SARS-CoV-2. And everyone recognizes the need to try to simplify as much as possible this very complex vaccine schedule. And the updated recommendations are actually meant to be simple or simpler and singular, possibly annual for most people, and yet also to allow for some flexibility for people that have higher risk, immunocompromised, or people 65 and older, and also to allow some customization for young children, kids who are COVID naive, kids who age into the recommended age for vaccination. So they're trying to take all these things into consideration. I wanted to point out a couple of main points. The first, as of April 18th of this year, the monovalent mRNA vaccines, so monovalent Moderna and Pfizer vaccines, are no longer authorized for use in the US. Times have changed. Bivalent vaccines, the bivalent mRNA vaccines, are now recommended for all indications when an mRNA vaccination is appropriate. What this means is we've actually moved from the many products that we did have available more in the center of this slide to the smaller amount of formulations that are available on the right side of the slide. So currently we have 2 Moderna formulations that are available. Both are bivalent. One is a dark pink cap, one is a dark blue cap. Please realize the dark blue Moderna will be used for almost everybody. It is for people 6 months and older, and details are in the table in the clinical consideration. But most people 6 months and over who are getting Moderna will get Moderna dark blue cap. The dark pink cap is for a very small subpopulation of children. The dark pink cap is only used for children 6 months through 5 years of age who have already received 2 monovalent doses of Moderna. And again, Table 1 and Table 2 in the clinical consideration details when to use each. For Pfizer, we have 3 formulations. We're somewhat familiar with them at this point. We have the maroon for the youngest kids, the orange for the slightly older children, and the gray for ages 12 and up. Novavax, we still have the 1 formulation. It's a monovalent. The mRNA bivalents are recommended, but there are instances when they can't be used, so Novavax is an option. And there is no more Janssen in the United States. It has all expired. It is no longer available in the United States. I also want to let you know that the fact sheet for healthcare providers actually no longer uses the terms primary series, or booster doses. They're getting away from that wording. Moving forward, things are being called doses, a bivalent dose, an additional dose. So just wanted to let you know that language is changing slightly, although we certainly still see booster, and the public, I think, has come to recognize that term and uses it very often. Couple more main points about COVID. CDC recommends people ages 6 months and older receive at least 1 dose of the bivalent mRNA vaccine. The number of bivalent doses will vary by age, vaccine, previous vaccine history, and the presence of any moderate or severe immunocompromise. And again, detailed schedules can be found in Table 1 and Table 2 of the clinical considerations. Here's links to the fact sheets for Moderna and Pfizer. And I wanted to point out the bullet in the middle. Most people age 6 and older who are not immunocompromised and have already received a dose of bivalent mRNA vaccine don't need to do anything more. They're all set. What the latest recommendations and the latest updates did was provide some more flexibility for people who are 65 older and immunocompromised. Let's take a look at school immunizations. The Massachusetts school immunization requirements are updated yearly, and were just updated in March. The school requirements outlines the required vaccines for childcare and preschool, for grades K through 6, grades 7 through 12 in college. The requirements apply to all students, even if they're over 18, and it also applies to individuals from other countries who are attending programs like exchange programs or an academic visit. The school immunization requirements also include the continued phase-in of the men ACWY requirement that began back in the 2021 school year. Remember that men B is not required and does not meet this requirement, which is for the men ACWY. And I want to take a few minutes to talk about the vaccine adverse event reporting system. VAERS is the nation's early warning system for vaccine safety. It's just one of the many vaccine safety systems that we have in the United States. It was launched back in 1990, and it's co-managed by the FDA and the CDC. I like to say that it was designed to be the canary in the coal mine, meaning it was meant to offer a quick way to identify potential vaccine safety concerns. It's a passive surveillance system. Anybody can report to it. It was designed and put in place to identify things like, is there a new or unexpected side effect following vaccination? Is there a higher than expected occurrence of side effects? Is there a pattern of people with particular characteristics who are having side effects? Is there any clustering of events with a geographic location or specific vaccine lots, and also to determine if there are any common vaccination administration errors. What it was not designed to do was to show causation. So reports that are in VAERS may be coincidental due to another cause, or they may be related. Last week, I read a nice analogy. It said, you know, one child might be given a teddy bear, another child might be given a vaccine. A week later, one of their teeth may fall out. Although one event happened after the other, it is probably, in this case, not related to the first. So again, once a potential safety concern is identified in VAERS, it can then be further investigated using other safety systems that are meant to look at whether there's any causation between the two events. So again, VAERS accepts all reports from everyone, regardless of the plausibility that the vaccine caused the event. Key strengths are that it can rapidly detect safety signals and it can detect rare adverse events. But a major limitation is that it was not designed to assess causality. And what do we report to VAERS? You know, as healthcare professionals, we are mandated reporters. We're required to report certain things. There's a link here on the slide of everything you're required to report. They're the major things. And then there are things we're encouraged to report. I always say that the bottom line is use your judgment. If you're seeing something unexpected, if it's out of the norm from what you usually see, if it's making you even question whether you should submit a VAERS, go ahead and submit one. If you do that, not only will you be covering yourself for everything that must be reported, but you'll be tremendously helping the vaccine safety systems in the United States. We all play a part. Every time you submit a VAERS, you're helping the safety systems. All right, I want to show you some of our favorite resources. CDC has a wonderful CDC Vaccine Schedules app. I have it on my phone. I've had many providers tell me how helpful it is. You can find it on the CDC eSchedules website. You can also find it directly from your app store. And there's also a Pneumorex Vax Advisor. It's another mobile app that is very helpful to have on your phone. It helps providers quickly and easily determine which pneumococcal vaccine a patient will need and when. It includes recommendations for all ages. And what you do is you simply enter someone's age, you note whether they have any underlying medical conditions, you answer a few questions about their pneumococcal vaccination history, and then the app will give you guidance. And the guidance is actually consistent with the IM schedule recommendations. Every time the new schedule comes out, I tend to look at my two apps to see how quickly they've been updated. And they're really updated very quickly within a couple of weeks. So two good apps to have. CDC has also developed some catch-up guidance job aids. If you work with children and you don't routinely use these, you really should check them out. Everyone who uses them loves them. And immunize.org, formerly known as Immunization Action Coalition, it is a resource that you should all know about and use often. Just about anything you want or need to know related to vaccines, you will find on this website, from vaccine information sheets to package inserts to really, really great reference materials. And speaking of reference materials, it is impossible to keep all the information you need in your head. Find your favorite resource materials and have them handy so that you can use them. Red Arrows, Immunize Express. This is a weekly newsletter. You'll get it in your email. I highly recommend you subscribe to it. If you do, you'll get immunization news and resources delivered by email every Wednesday. And then Ask the Experts. That Ask the Experts section has more than 1,000 questions on vaccines and vaccine administration, all answered by experts. I said I had some of our favorite pneumococcal vaccine resources. These are them. In addition, in the blue, the kind of greenish blue box, it kind of summarizes the recommendations, but these resources we use often, we recommend often, they're very helpful. And if you work with adults, one of those I'm highlighting here. This is the pneumococcal vaccine timing for adults. Really great series of visuals that help you determine what your patients need. Again, for COVID-19 vaccine information, it's complex, it changes frequently. Please go to the clinical considerations, and here's some major websites, vaccine safety resources. Here's contact information for us at the IM division. And here is the list of the immunization nurses that I am so honored to work with every day. I know a lot of you call and reach out to them with questions. So please, we are there to help if you have questions. And now we're ready to move on to questions if there are any.
Thank you, Lori, for such a great presentation today. As she mentioned, we're now going to start the Q&A session. If you have any practice-specific questions or a question that's very detailed, please reach out to immunization nurse. We're so happy to speak to you one-on-one in more detail. So we had several questions related to any updates on the vaccine schedule for school-age children. Have there been any additional vaccines required? And are the COVID-19 vaccines recommended or mandated for school-age children?
The recommended schedule or the school recommendations have not significantly changed. Other than there is that continued phase in of the MenACWY vaccines. And remember, you have your public schools have their school nurse liaisons who are great resources, and also our epi division folks who work with school immunizations are a great resource also, as are the IM nurses. For COVID-19 vaccines, they are now on the child and adult schedule, and there are some really great benefits of that, because once they're on the child schedule and they can be included in the VFC vaccines, and there's benefits regarding reimbursement and so forth. But no, at the current moment, there are no COVID-19 requirements or mandates by the state for COVID-19 vaccines.
Thank you. Another question we had was, do we know what RSV vaccine recommendations will be? So can you give us an update on RSV vaccines?
RSV, respiratory syncytial virus, has been a scourge for decades, really affecting those who are older and also the very young. And they've been working for decades on vaccine for RSV, and like so many viruses, there've been a lot of challenges. But just in May of this year, a couple of weeks ago, the FDA actually approved a RSV vaccine for those 60 and older, and I'm fairly sure it will be on the ACIP meeting for discussion in June. So we may be getting recommendations for a vaccine sooner rather than later for older folks. What those recommendations will be, of course, I have no idea. It will depend on what ACIP decides and then what the CDC director ultimately approves. There are also fairly advanced clinical studies going on right now for little kids and also for pregnant women, because of course, if we are able to provide a vaccine for RSV for kids, whether they're premature or young or born during the season when RSV is really prevalent, it will do a lot to decrease illness, suffering, hospitalization, etc. So those are in some pretty advanced clinical study phases right now. And we do expect probably for something to be approved fairly in the not too distant future, meaning this year, and then it will be discussed by ACIP.
Great. We have a we have a request that you repeat which MMRV vaccine can be approved for IM or sub-Q.
Oh, sure. So the older family of vaccines we're used to, I call it the MMRV family because it's MMR, varicella, and MMRV. And those are the ones that have been around a while, probably because they got a lot of VAERS reports of them inadvertently being administered IM, along with a lot of other study and data I'm sure that they looked at. FDA said it's fine to give them SC or IM. The issue is we now have this newer MMR vaccine, Priorix. That's new. We don't have years of study data about it. So the new one is limited to the sub-Q administration route. And this is just another example of why it's so important to look at package inserts, look at resource materials. When a new vaccine comes out, pay attention to where it should be stored in the fridge or in the freezer and how it should be administered. And I will say that the immunize.org reference sheet that I can't remember exactly what it's called, but it lists all the vaccines and how they should be administered. It has already been updated and it breaks out MMR2 from Priorix. So again, have a nice reference sheet like that to go by.
Great, thank you. With all the changes with the COVID vaccine, someone had a question. If a child under 11 started the series with Moderna, but switched to a practice, could they continue with Pfizer?
So I always say, look at your resources before answering. I am almost positive, my memory serves me, Madeline, maybe you also know the answer, can reinforce this, but for that age group, I believe it is, you said primary series?
Primary series.
Okay, so there are a couple of things here, right? Because there isn't a primary series anymore for 11-year-olds. If they're immunocompromised, they may need a couple of doses. If they're not immunocompromised, they only get one dose of the bivalent. So there isn't a primary series. For people that do need a primary series, the general guidance is to use the same product, but the clinical considerations does list that in instances where that's impossible, such as you don't know what the original product was, or you do not have it. So that's what you're describing here. If it is a situation where you don't have it, then yes, you can. For this age group, for the younger kids, there are some differences.
Thank you so much. Lori, can you briefly discuss the grace period given for vaccinations?
Sure. The grace period is, it's a 4-day grace period. And what that means is you have this 4-day grace period for the minimum age or minimum interval. So if somebody is supposed to get an MMR vaccine at age 1, and they come in for their appointment 2 days before their first birthday, this allows the provider to be able to go ahead and give it and not miss that opportunity. The same thing with the minimal interval. If somebody's coming in for any vaccine on a certain day and the minimum interval is a couple of days in the future, you can go ahead and give it. It is only 4 days. It cannot be 5. Most everyone goes by this, but we always do the caveat that there may be an employer or there may be a college or university that is a real stickler. I've actually never come across a situation where somebody didn't accept something within the 4-day grace period. You should also never use that 4-day grace period to schedule a vaccine. It is only to be used either in retrospect to determine if a dose was valid or not, or like I said, if someone's in front of you and you're not going to get them back in 2 days for a vaccine, you can go ahead and administer it.
Thanks so much. We have some time for maybe 1 or 2 more questions. This one is related to hepatitis B. If an adult completed the series before in the past, is there any recommendation that they need repeat hepatitis B vaccines any time later in life?
No, there isn't, unless you're a healthcare provider. So a healthcare provider, if you work in a hospital or a setting where you are covered under the guidance for hospitals, in that case, they'll want to know that not only did you have a series of Hep B, but that your antibody level showed that you were truly protected. So again, most adults, you have your series, you're all set. If you are in healthcare, you should be check your antibody level after a series to make sure you have adequate protection. And if your protection isn't adequate, you can have additional doses. There is a small subset of people who are just non-responders for some reason. And if you're a healthcare provider and you're in that category, there's certain guidance you have to follow if you ever have an exposure. There's no simple yes, no answers when it comes to vaccines.
Well, thank you so much, Lori. You're just a wealth of knowledge. And that's all the time we have today, unfortunately, for questions. So if we didn't get to you, as we mentioned earlier, feel free to reach out to one of the immunization nurses. We want to thank everyone for joining us today. We hope you enjoyed this presentation. You can follow up with us, our presenter, Lori Courtney, or Ted Clark, who was on earlier. You'll find email addresses in the chat on how you can get in contact with someone, along with the links to the material and our events page where the webinar will be made available. Have a great day, everyone.